Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. My name is Chow Yen, and I am a medico-legal consultant at MPS and an anaesthetist for Te Whatu Ora. I'm very lucky today to have with me Sarah Dalton, Director of the Association of Salaried Medical Specialists, ASMS, Dr. Sam King, Fellow MLC and GP, and Dr. Tim Cookson, also Fellow MLC, recently retired. Thank you for coming, Tim.
Cheers, Cheyenne.
Hello, everybody.
Hi, Cheyenne.
So today we're going to talk about industrial action, because in recent times, this has occurred in many areas of the healthcare sector. And in the last few months alone, we've seen industrial action from the MRI technologists, the Resident Medical Doctors Association, the RMOs via the RDA, and the blood bank laboratory technicians. Every union has responsibilities and obligations to ensure the group providing industrial action sets up the process appropriately so that the union members can negotiate to improve their working conditions but still provide care for our patients. So I'll get Sarah to talk to us about this process, the first steps required in initiating industrial action. Thank you, Sarah.
Kia ora. So there's two types of industrial action that a union could take, and we have seen both those types in recent years. So there can be the type that most people think of, which is workers going on strike because they can't settle their collective bargaining and they can't reach agreement with the employer, so they choose to take industrial action by striking or partial strikes. But there is also a health and safety strike, which is allowed for under the Employment Relations Act. And you've seen NZNO have a couple of health and safety strikes. The first one was the Ward 5 nurses at Tairāwhiti, Gisborne Hospital. And recently there was one up in Dargaville over lack of safety. So that is a different process. But the bulk of strike action, first of all, bargaining has to have been going on for 40 days at least without coming to a successful conclusion before a union can undertake industrial action. And at that point, if it's determined that they wish to undertake industrial action, there has to be a secret ballot of the membership. So I can't, or our president or executive can't just say, right, we're going out on strike, let's get out there. It's got to be a majority of the members. And to be honest, unions don't do it lightly. It is, generally we try any other means than strike action to get the result that we're trying to achieve for our members. And before taking industrial action or asking members to go on strike, we always think really carefully about what are the potential wins, what are the risks, what are the impacts, and particularly if senior doctors take strike action, which we did do last year, that is something that weigh very heavily on our executive and required a lot of thought. Looking back, we think it was the right thing to do, and it did help to settle the collective agreement, as well as, I think, really coalescing public attention on a number of the resourcing challenges across our public hospitals, which of course we still have. So anyway, you have to have a secret ballot. Then there has to be a 14-day strike notice in writing to MB, who oversees all of these things, and also to the employer. So if you want to go on strike Tuesday, 2 weeks' time, it's got to be the Monday, like the 15 days before the notice would have to go in, and then off you go.
So when you were talking about being able to provide services during the strike so that the hospital can prepare, when the RMOs were striking earlier this year, we had some members phone in because they were concerned that they didn't have enough SMOs to cover the service so that they couldn't run the day-to-day elective services or acute services during the strike.
Yeah, so if I focus on elective services first, obviously the point of a strike is to withdraw labour, which means business as usual cannot continue. And the hospitals really hate that. But that's the reason for a strike. is to put the employer under pressure and to stop them from providing services. So you shouldn't be providing elective services when a whole workforce group are on strike. You should be saying to the community, we're really sorry, just in the way you do if lots of people are sick and you have to close a theatre. We're really sorry, but we can't deliver our usual full range of services. If you're very, very sick, you should still come to the ED or call an ambulance and you will be cared for. But unfortunately, a number of clinics and a number of planned surgeries will not be able to happen, and we will let you know when they're rescheduled. And so that's what should happen. Typically, we find that Te Whatu Ora tries really, really hard to minimise the impact of strike action and tries to encourage whatever staff they can to cover for that missing workforce group. For the RMOs, because there are two unions, there will be some services that will have lots of people on strike and some that might not have so many people on strike, or it might be a split depending whether they're on the RDA or Stones. So for some services, if they had lots of Stones members, they might have been able to maintain close to normal services, but another service with lots of RDA members would need to make significant changes to what they attempt to do on that day or on those days.
I see. So it's, I guess, during strike action, it's very similar to, for example, one of our previous podcasts on, severe resource constraint in the public sector, where we had a situation where emergency services couldn't be covered by a given specialty. So let's say it's a paediatric service, they can't run their emergency services. Do you have any ideas, Sam, for this group of clinicians if they find themselves in a situation where they can't even provide emergency care for paediatric patients coming in on, say, those 2 days?
Yeah, we often get called by SMOs from around the country, not necessarily because of strike or even acute staff shortages, just it's the general staff shortage is really severe, and where a lot of them are working beyond their capacity. And so usually what I advise the members, obviously the first thing we do is, you need to raise this as a safety concern to the management and cite what they see as being specific patient safety concerns. Because at the end of the day, the health system exists for our patients, and patients should be central in the way that we think. So to raise patient safety concerns, I think, is really important. I think that there needs to be a lot of planning, and unfortunately, I think that needs to come from not just the clinicians themselves, it must come from management about how they intend to cover those things, how they intend to notify the public, what they're going to do if these emergencies come and you've got too few ED consultants, for example. How are you going to, because you can't have people turning up into ED and you've got these clinicians who go, well, who do I help first? Who are we going to let die or, bleed out or whatever it happens to be? So I think a lot of planning and management needs to go in place. And then, so we're thinking about the clinical situations and the patients, but we also have to think about the clinicians themselves. It becomes unsafe for the clinician. And so if you are working beyond your own physical capacity, let's just say you're exhausted, you haven't slept for 24 hours or whatever, and you physically are becoming unsafe to be treating patients, then I will say to them that they need to be able to withdraw from work and say that I'm unfit to work. It's not just about I feel a bit tired and I've got another function I need to go to, but this is about I'm a risk to patients if I continue. I think that it's right, appropriate for them and the patients if they withdraw. I know, Sarah, what are your thoughts around that?
Yeah, I was thinking, because we not infrequently, unfortunately, have services say we are on the verge of losing our ability to provide acute services. So, for example, the example you gave of PEDS, basically every hospital has contingency planners, and I'll talk more about that in relation to strike action shortly. But if a service is unable to provide acute care, then there will be a contingency plan which involves transporting those patients to another hospital. But depending where that is, if it's a major urban area, it might mean a 20-minute ambulance ride. If you're somewhere else in New Zealand, it might be a 1 or 2 hour flight with all of the other logistics that involves. So that is really significant. And obviously, if the inability to provide acute care in a service is more than just for a day or two, there are also the other potential outcomes of that, which is no longer able to train, no longer, all kinds of things. But also, the impact on families if you have a child or another family member who has to be removed from their home area for care is massive, right? All kinds of extra expense, all kinds of extra stress. It's not desirable, and no one wants that to happen. But unfortunately, that is increasingly part of the health picture in New Zealand.
Which is why we're
Yeah.
asking for better conditions.
Yeah, that's right. That's right. So the fight for better terms and conditions is very much tied up with our members, and I think the members of other health unions sense that in order to keep people in the public system and out of the private system, or in New Zealand as opposed to in Australia or somewhere else, there need to be terms and conditions that better reflect, the challenges of the difficult work that they're doing, and also to entice enough people in here so that you have well-staffed services with a little bit of flex. So for our union, unfortunately, a number of the terms and conditions that sit in our collective are predicated on full staffing most of the time. And where services are fully staffed, that means that SMOs can be a bit flexible if someone's off sick or off on sabbatical, because at the end of the day, there's enough people that you can manage those ups and downs, and you can also do the full scope of your work as a consultant. Increasingly, it seems to us that SMOs are being required to work entirely in patient-facing work, not teaching, not planning, not auditing, not developing new models of care, or, doing all of the rich array of things that are the full expression of a consultant's role. And I don't think there is a strong understanding of the importance of that in terms of looking after our workforce so that, you have fulfilling working lives and sustainable working lives.
I think ultimately that negatively impacts patient care if you've got no forward planning, innovation, all of those things. And if you don't have the time to think about how are we going to deploy all of our staff in the best way possible, then ultimately patients do miss out.
Oh, completely. And also an over-reliance on locums, discontinuity of care. There may be a number of things that locums don't do, so it's all reactive, it's all hanging on, it is all just how many lists, how many beds, how many clinics. That is not a rich way or a productive way to run a health service, and typically our hospitals are running at 100% plus most of the time. So that's inefficient in and of itself. I know we've drifted a little bit, but I guess that's why if a strike notice is issued, hospitals will be looking in the days leading up to the strike period to try and empty out the hospital as much as possible to create a little bit of wiggle room. And of course, when we went on strike, with our members being the key clinical decision makers, that put a lot of pressure on the hospital management, whereas other strikes, while they put pressure on, and I think particularly nurses in terms of numbers and things, they still have the SMOs there to do triage, to do clinical decision making, to help ensure things are safe. And so that is a heavy burden that our members carry when other work groups go on strike. But when we went on strike, that caused real distress, I think, to hospital managers, because they realised that a whole layer of the key clinical decision makers was gone. So that was a really interesting challenge. So I guess you can't just go on strike and not put things in place. So there's a thing called Schedule 1B, the Code of Good Faith for the public health sector, which is part of the legislation. And that requires that LPS, or life-preserving services, are agreed when a group like doctors or nurses or allied health workers go on strike. So when we issued our strike notice, the employer immediately came to us and said, we We want to put LPS arrangements in place, and that is effectively a negotiation between the union and the employer. They're not all women, but the bulk of the contingency planners seem to be women, and they're those super organised, amazing women, like really smart and really sensible. They should probably be running the health system all the time, and we'd be in a better place.
It's definitely a whole nother conversation.
Anyway, we had, it was really interesting listening. And so basically for every single hospital and every single service, they put up a proposal for how many SMOs they thought they would need to provide life-preserving services. Now, the definition of a life-preserving service is to protect life, to protect limb, to prevent lifelong disability. That's about it.
It's very narrow.
It's to stop people dying, right? Or to have suffer a permanent disability that they otherwise would not have suffered. So it is actually quite narrow, and explaining to hospital managers and sometimes to our members as well where the lines are around LPS is quite challenging. And I found it really challenging too, because I have no clinical background. So I tried to have one of our exec members with me so that they could potentially talk doctor if they had another doctor. So typically we did a whole series of Zooms with the different hospitals, and it would be the contingency planner, and often it would be the chief medical officer or someone like that in the hospital to talk about, okay, radiology, what do we need?
Yeah.
Okay, anaesthesia, what do we need?
So along those lines, could ED doctors or ED doctors, can they go on strike?
Some of them can. Yeah, absolutely. Some of them can. And in fact, we did a deal with a number of the hospitals that said if someone is within 5 minutes or 10 minutes, but often 5 minutes of the department, will you let them go on strike? And so we kind of had these halfway rules so that, if we were picketing, that like at Auckland Hospital, we had the picket by the gates of the Domain, which is, just 2 or 3 minutes kind of jog from the ED department. And they said, oh yeah, if they're that close, we will only require like maybe one SMO there, and you can have another 1 or 2 that are nearby. So that if nothing happens during the time of the strike, but they're nearby, they can do that. So that's not a typical arrangement, but it was one that actually freed up more of our members to be able to join the pickets and talk to their colleagues. And I know this isn't what this podcast is about either, but one of the things that I think our members really loved about the opportunity to stand together with their colleagues was they had all of these really interesting cross-service chats, and they saw people that they don't usually get to see in their normal working day. And I just
built
think
teamwork.
But it does speak volumes about how siloed SMOs become, and also that sometimes they don't even get to spend time with their colleagues within their own service because they'll be working with junior doctors and nurses in allied health, but they might not be having those corridor conversations with other SMOs from their service, and certainly not from others necessarily. So they really loved that. Yeah.
It must be tricky when you've got to make a decision, is this life preserving or is it not? When you think about, if you see someone with chest pain and you think it's potentially life preserving, but you don't know at the time because you haven't looked into it, you haven't investigated. So it must be quite difficult to know who you can treat and who not to treat when you're on strike.
Well, I think, as we know, with our overloaded waiting rooms, there have been recent events that show that it's pretty unsafe for undifferentiated patients having to wait a long time in any case. And I guess that's part of the point, that we really need to staff up our health system if we want to make it safer for the people who need it.
Absolutely.
I think probably on balance we were more generous with our LPS arrangements than we strictly needed to be. And that served us quite well, I think, in a lot of ways, in terms of both giving our members the confidence that it was safe enough for them to be on strike for a period of time, and also preserve some relationships with managers around the place.
It's a fine line, isn't it?
It is a fine line. We don't want to cause harm.
No, and that's the thing that most clinicians, well, all clinicians, that's the concern, is we all feel a duty of care for patients, and to let people not be seen, I'm sure must be extremely difficult for your members.
It is, but I think the employer uses it against doctors and other health professionals all the time, right? So they have all of that advantage, of saying, well, we can't afford more staff, we're not going to advertise for more staff, blah, blah, blah. And then when the staff turn around and go, you know what, we've had enough. This is not safe, it's not reasonable, it's not sustainable. So we're stepping out for a moment to ponder that and let the public know what that means. Then all this pressure comes down on them, and we've got to understand that while when you are seeing a patient as a clinician, then that is absolutely your responsibility. Their care is your responsibility. But when you're not directly seeing them, the responsibility sits with the system, not on the shoulders of individual clinicians. And there is a lot of that shoving that obligation way beyond, I think, your professional and ethical obligations as doctors that happens in our health system at the moment. And
I guess the dilemma for SMOs would be that there's a risk of someone coming to harm in the short term because of industrial action. But if conditions have got to a point whereby in the future there'll be harm because there's not enough staff or whatever, then you're balancing up patient harm potentially now versus patient harm which will occur later.
Yeah. I think, I mean, we went on strike on 3 or 4 occasions last year. I went to a different place every time, and certainly when I was standing with our members and interacting with members of the public, I would have said 90% of the interactions, maybe more, were positive. People were incredibly supportive. They were incredibly grateful to doctors for the work that doctors do and understood the reasons why our members were out there on strike. So, and I think that was really powerful for our members as well, knowing that actually the public understand what they're trying to achieve and support that and know that there is a greater good. It's not about me, or, give me more. It's actually about trying to rebuild our health system to the extent that it's safely staffed and sustainably staffed for best care.
Yeah. So when we're planning for strikes, if you're really short-staffed already, so for example, in this case, if the paediatric RDA members are going on strike and there's not enough paediatrician SMOs in that department to run the service during the strike, you'd approach it like any other situation where you're severely resource constrained. You'd get locums if you could, but everyone would be trying to get locums probably.
Yep, absolutely. You would get locums, or you would say that they would have to be diverted if they were really unwell to a larger centre. Now, obviously, we were running national strikes, so there would be issues everywhere, but there would be some centres that might be able to. Or if there was a non-member or a volunteer, they might say, would someone,
I see. So close the service.
Oh, yeah, they might have to close
diversion.
the service. Yeah, absolutely. Yep.
I was just picking up on one of the comments you made, Sarah. You said about if you've got a patient in front of you, you've got a duty of care. And I was thinking, Tim, have you got a case around that?
Well, there's certainly a case that I wasn't involved with, but it occurred during a time of industrial action. And this was a 60-year-old patient with prosthetic heart valve problems who was experiencing syncope. So she presented to her local ED twice and was discharged with a diagnosis of a vasovagal attack on each occasion. However, she unfortunately later died, and the post-mortem showed coronary artery insufficiency, and it was inferred that her syncope was due to malignant arrhythmias. Her husband advised the HDC that subsequent to the death of his wife, staff at the hospital informed him that a memorandum had been issued to staff by the hospital to limit admissions in preparation for strike action by the doctors. In fact, the public hospital did publish an open letter which advised about the strike action when it was going to occur, that elective surgery and outpatient appointments had been mostly cancelled, but that emergency medical care would be available on a limited basis during the time of the strike. So it's quite possible then that the advice or the information given in this open letter created an impression for Mrs. A's husband, the patient's husband, that the strike action led to an altered decision-making process about his wife's admission or otherwise to hospital. Certainly, I think the HDC took a similar view, and in fact, it was the individual who was breached, the doctor, or the service?
So one of the doctors was criticised. The one that saw this patient second was criticised and breached because this patient wasn't admitted and or referred to cardiology, and the expert opinion was that at this point, in a patient like this with a heart valve replacement, there is a significant risk of arrhythmia when they're presenting with syncope, and they needed to be monitored. And it was unfortunate because I think you're right, the patient's husband misunderstood the information that he was given. He thought that they were being sent home because the hospital was trying to ready itself for a strike, when actually it was just letting the public know that this was going to happen.
Except that the clinicians involved may well have been influenced by the fact that the strike was about to occur.
100%.
And in a 50-50 situation where they might have been debating whether to admit or not to admit, then they would take the not admit route rather than the admit route.
Absolutely. And even though in this case the second doctor who was breached said that, that wasn't why he sent this patient home, there was certainly that strong impression that the resources were being limited.
Yeah, of course, it's very hard for him to be able to categorically state it had no influence on me, because we know that those things do definitely have an influence. And the more you deny it, the more likely it is probably that in fact it was an influence. So
I would have thought, though, our view is that readiness for strikes is about decanting patients out of the hospital rather than preventing people from being admitted. I know it's kind of two sides of the same coin, but the focus for hospital administrators and clinicians prior to a strike should be reviewing patients who are already occupying beds about whether they're ready to be sent home, and to focus lots of effort into clearing those beds, but not preventing people from being seen or potentially being admitted if that's deemed appropriate. But I take the point that you're making, that there may be that impact on your thinking and your decision making, given that hospitals putting out notices about
a mindset that we've got to keep the hospital as empty as possible to cope during strike action.
Yeah, I think that for all the clinicians who might listen to the podcast, once we start consulting with a patient, we owe them a duty of care. And so the only focus ought to be, but I'm sure it's hard in practice, is to say, well, this is the patient in front of me. What do they need? And I need to provide a complete consultation. I need to be thorough and do all the things I normally would, were there not a strike happening or resource limitation. I know that's difficult, but when it comes to complaint, the HDC are going to be scrutinising your specific care.
Like they did here.
Yeah.
And actually, one day is often not that different from another. And I know the midwives complained, and some of our members complained too, that under the LPS arrangements, they felt some services were better staffed during the strike than they were on a normal day. So, the midwives were very clear that when they were undertaking strike action, what the hospitals required in terms of midwives on duty was more than they would normally see, because there are such shortages of midwives, right? So that obstetric wards in some hospitals were better staffed during the strikes because of the LPS arrangements than on a normal day. And
they should strike every day then.
Yeah, and in some services, some of our members said, well, we wouldn't normally have that many people floating around. That's ridiculous. So, yeah.
It's a bit of an indictment on the overall state of the health system then, isn't it, if that kind of thing occurs?
Oh, yeah, and there's a complete two-facedness of the way hospital management works, not personally, but at a systems level, in terms of how they respond to staffing shortage or what is enough staff. depending on the circumstance. Yeah.
So, Tim, there is another example that we were talking about a patient that had was referred to an emergency department at a public hospital after a consultation at urgent care. He had sluggish speech and he was unable to maintain his balance. He was seen by a neurologist who advised that he needed an MRI scan, but because the technologists at the hospital were on strike, the neurologist suggested that he go to the local private hospital for the MRI. For that time, but they couldn't access the MRI, so the patient was admitted and then sometime later deteriorated and then had to have an MRI. So in that case, the there was a complaint to the HDC. Are you able to comment on what they found about the delay in the imaging?
So the findings of the MRI were that he had an acute cerebellar bleed and required surgery. And the comment from the HDC was that a DHB's legal obligation to ensure that services of an appropriate standard are provided to patients is not suspended during a strike. So there's a clear expectation that services need to be of an appropriate standard, presumably within the life-preserving bounds that had been agreed. However, that a provider can only be expected to take reasonable actions in the circumstances, which is one of the basic tenets of the code, and obviously the circumstances prevailing at the time. And on balance, the HDC felt that because of the exceptional circumstances of the strike, the hospital's response was actually reasonable and it didn't breach the code.
So the initial delay was reasonable because they couldn't access it straight away. Because
of the lack of availability. And it's interesting when we look at HDC cases and how much they take into account the circumstances. It clearly does vary. And we've all had times where we've thought that the circumstances warranted a much greater consideration by the HDC than were actually given. But it's good to see that in this case, the HDC realised actually the individual concerned really had no opportunity to change that outcome. And likewise, the service itself was doing the best it could in those circumstances.
Right. So do you think that's why they put on discharge summaries during strike action, that this care was provided during a time of industrial action?
Well, it's similar to during COVID times when we were always advised to, consultation during COVID, level 2 or whatever it was, so that, in retrospect, you can't often remember if the complaint comes in 18 months later, was that during the strike? Oh, I can't remember, So having that recorded at the time is really useful, particularly for us at MPS to be able to assist in using that.
So I think even in general, if your department is short-staffed for whatever reason, sickness or whatever that is, it's always good to be able to have some short mention in the clinical notes, because I agree, it's too hard to think about it later. But there was one thing I know this is about secondary care, but I have to just mention our primary care colleagues.
Yes.
That when there's a block in the hospital, there's that backflow to primary care. And that creates a huge issue, obviously, because one, it's already hard to get an appointment with a GP. GPs are very hard pushed anyway. And then you get decisions that GPs have to make. Shall I refer this patient to hospital or not? And so often there'll be some GPs who will take on more responsibility than perhaps they ought. So I think it's better for us to phone the hospital, try and get someone admitted, rather than sitting back and go, well, it's very unlikely they're going to be seen, so I'm not going to send them in, and then something untoward happens. I don't know. As a GP, what do you think, Tim?
We certainly had lots of cases at MPS like that where the doctor stated, look, it didn't seem worthwhile bothering to go to all that time to send a referral because I just knew it would be rejected, even if the pathway suggested that was the appropriate thing that would be rejected. And it's understandable because there's nothing worse than doing futile things over and over again.
That's right.
It certainly influences your future decision making. But unfortunately, from a medico-legal point of view, it's actually not a defence. And you're right, Sam, we do need to be seen to be taking the appropriate steps, just for self-protection, really. If that means that someone else then becomes responsible, well, that's a tough call. But as a primary care physician, why would we be expected to take responsibility for something that's actually completely out of our hands?
Yeah, and I wonder if all of us need to provide more information to the patients to say, look, in the ideal world, this is what I would like to do, but unfortunately right now, this is what's possible to do. And so the patients are then perhaps in a better position. Let's just say they want to go privately, or they've got some other avenue available to them, rather than the patient just thinking, oh, my condition doesn't warrant any further investigation, if that makes sense.
Mm-hmm.
So the communication is huge, because I know I've sat with groups of hospital doctors in a service who are angsting because they're so short-staffed. They're like, we can't keep doing all of the things that we want to do or that we're supposed to do. So now perhaps we won't review the P3s, or these certain conditions, we're not going to bring them back for a 6-month or a 12-month review. But there needs to be letters out to GPs, to referrers, to the community, so that they understand what is continuing and what can't continue in a service for those reasons, and what that then means, right? And often our members, who are largely hospital-based, are reluctant to take that step, or they are discouraged by their managers from taking that step. And actually the letters should be going from hospital management, not from the doctors themselves, to share that information. But I think those information loops are incredibly important, and it's not about scaring people, but we need to be a lot more upfront with the public, whether it's strikes or not strikes, about what's going on in hospital services. Like the fact that in lots of parts of the country now, if you have non-cancer gynae, you're not going to be seen.
That's right.
So people need to be really clear about that and what that means. And then what are the guidelines for GPs who are stuck with this ever-increasing burden of patients who, by rights, should be referred on, and there should be a place for them in the public system, either as outpatients or inpatients, but there isn't. And what does that mean? And what does that mean in terms of potential disability or impact on that person's ability to work or get around,
and suggested management if you can get in to see your GP.
Yeah.
Because it creates a situation where GPs may then be expected to cope with situations for which they're not properly trained, because these are people who up until now have been looked after by specialists, and they've had the letters which explaining what the treatment might be, but suddenly taking responsibility for prescribing medication they've never prescribed before, in the hope that will still continue to be the right thing.
Yep.
And it isn't always the case, as we know. And one of the areas I think that's missing is discussion between the hospital managers or clinicians who are making that decision and the GP community, to say, look, this is the scenario. How can we best work it out? Because I think it's inherently unfair on primary care for a hospital service to suddenly say, this is your responsibility now. We can't do it. It's your responsibility, particularly in a time when GPs are dropping like flies. So.
Oh, absolutely. And in terms of regular follow-ups, if you've already got a full caseload, your books are closed or on the verge of being closed, and then you're being told you've got these patients whose annual follow-ups are no longer going to be picked up, but someone probably needs to see them. Who's going to manage that? How's that going to work? And I think that was one of the hypothetical opportunities of Te Whatu Ora, that we were going to get more examples of integrated care and integrated pathways and more opportunities to talk across the whole spectrum of healthcare and to the benefit of patients and clinicians. But it feels a bit like the opposite has happened so far.
It's because everyone's in emergency. We're feeling like we're on emergency footing. We can only do the bare minimum right now, and we haven't got time to think about how can we make the whole health system better. Yeah. Sorry, I've digressed into primary care, and I'm not sure that was the intention of this podcast.
Oh, no problem. It's all about industrial action.
You could still have industrial action happen in a primary care setting.
And
You
have done, haven't you, with practice nurses?
Yeah, that could happen.
I think they've...
That would be an interesting topic for another podcast. Yeah. I know that there'd be some of my colleagues in primary care who would love to do that.
So we'll quickly touch on fronting the media because during industrial action, it's all over the news. There's increased attention on our profession, and it's not unusual to be approached by media, whether it's on the picket line or as a spokesperson. But just bear in mind that we have had members who receive complaints to Medical Council about how they came across, not necessarily in industrial action per se, but on social media or in the news when they make their comments. And so we should all be mindful of how we present ourselves and how we conduct ourselves, because we're all obliged to behave in an appropriate way. Do you have any comments about that, Sam, when you're fronting the media, if you're sharing an opinion or...
Yeah, we do get calls from members who haven't been approached by a reporter but want to approach a reporter. And I think the thing to remember is that the reporters don't necessarily report everything you say. They will just take snippets of it.
That's right.
So it's easy to be misrepresented and present you in a way that that misrepresents who you are and what you're trying to do. And the other thing is that you lose control. Once you've given your statement or interview, you've lost control. You can't say, can I have a look at that before you print it and then make changes? They won't allow that. They will print what they want, and then they will go chase down any rabbit hole that they want as a result of what you've said. So I think if you do decide to approach the media, you do need to think about that. And there's probably, or especially for people who work for Te Whatu Ora, you've got employment issues, and often the employer has policies or have issued instructions around speaking to the media, which I think you would be best to look at.
Yeah.
Okay, so I'm going to jump in here because our members, most of whom work for Te Whatu Ora, in our collective agreement, we have an absolute right to speak up, that we defend to the hilt. But that said, we find doctors who speak to the media in general are incredibly reasonable and evidence-based and even conservative in the way they present themselves. So, but we also have a comms team who will give advice and support. So if you want to speak to the media, whether it's in a strike context or another context, if you let us know, we will give you a hand. I think, but the points you raise are absolutely correct. We have had people who've written sort of, I guess, like a letter to the editor or an op-ed that's been published, and they are more likely to be printed complete. But yes, if you talk to a journalist, they may only pick up some of the things, well, they will only pick up some of the things you say, especially if you're like me and you have lots on your mind. So only a fraction of what you say will be printed, and you're never sure what the context will be. So it's something to be mindful about. But in general, I find our members do a fantastic job of speaking to the media, and you must remember that it is your right to speak up, and we will protect your right and defend your right to continue to do that. I think it's in all of our best interests that doctors and other clinicians continue to speak up and talk about what things are like at the front lines of healthcare.
I think that's a great tip there, that you've got a media team that will help them. I think that's fantastic news for us. Yeah. So maybe we'll just point our members in your direction.
Yeah. There were one or two sites I'm thinking about that had some quite creative and theatrical approaches to their pickets last time, and they picked up some fantastic media, but some of it people thought was perhaps borderline in terms of whether it was an appropriate thing to do. Costumes were worn. But I thought in general it kind of added to the festive nature of the protest, and the fact that it was actually largely about trying to promote a better health system. And so it created a mood, I thought, that was quite positive and quite engaging. But I guess it's something to think about when you get carried away in terms of what you want to do to make it fun, or you want to really push your point, think about how someone else might view it. I'm still in favour of what they did, but I know there was a little bit of pushback around a couple of those.
And I guess as a union, you're going to be quite concerned about having a reasonably consistent message going out. And if you've got a whole lot of different people making comments, then the likelihood that there'll be a variation in the message will increase significantly, won't it?
Yeah, absolutely. But, we trust our members. We know they know what the issues are. And we, although interestingly, we printed T-shirts that said invest in our health. And we decided to have red T-shirts because ASMS's colours are kind of red and gold. And then people thought that we'd pick them to align with a political party.
Oh, I see.
And that never even entered our minds. It was all about our ASMS brand.
Read anything into anything you like.
So you never know how people are going to take things, and I think we're going to get a whole bunch more T-shirts. A bunch of them were being worn in the Dunedin, at the Dunedin rally last week or over the weekend, and I wore mine at the Westport rally. But I think our next round we might get printed in a range of colours so people can
read more into it.
or less.
All right. Oh, thank you so much.
Black and yellow into blue. And a green.
Thank you so much for coming along and helping us with this podcast. Any last comments from anyone? No. Thank you for listening to this podcast. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.